well over 90% of all facilities still document by hand. And what that entails is literally handwriting the date of the exchange on the curtain label, and then taking that information to the EVS office, where they typically maintain a spreadsheet in a 3-ring binder, and then document in that 3-ring binder. So needless to say, again, if you think about it, again, we've got a staffing crisis. Folks are running out of time. They need to get patients in and out of these rooms really quickly. The curtain has to be taken down. Are they really documenting these isolation exchanges?
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now it's time to roll back and start the first case.
This week on First Case, we are speaking with Karen Goelst, CEO of KleenEdge, and we're going to be talking about technology, data, and then how do we get that in the easiest way, leveraging technology that we have today to drive outcomes in the end. And I feel like this conversation, Paul, is going to tell us a little bit about us being in the dark ages and let us know that we've got quite a bit of a way to go, especially in this particular area of focus for Karen today in this conversation.
Oh, absolutely. I think the fact that even today we still are tracking specific things that we have to monitor in a binder with handwritten notes that probably doesn't get looked at frequently enough is a real big issue. And I think her technology, from what I've seen, looks like it's a solution to some of this. I'm looking forward to hearing the future of where it's going to go.
All right, we're going to be back after a short break with Karen Goelst, CEO of KleenEdge.
Hi, I'm Paul Wafer.
I'm Melanie Perry.
And I'm Justin Poulin.
A 17 Studios production, you're listening to First Case.
Joining us now is Karen Goelst, CEO of KleenEdge, and we're going to be talking about leveraging technology to do something that we talk about quite a bit in this industry. It's collecting data and driving outcomes. But how can we leverage that technology to do that? Karen, really excited to have you on the show today. Thanks for coming on.
Oh, thanks for having me, Justin. It's really exciting to be here.
Why don't you tell us a little bit about your background?
Yeah, so actually I'm originally from the Netherlands, where I come from a third generation of window treatment focus, basically, in that we did drapery hardware, a special focus on cubicle tracks in healthcare.
Excellent. And what are you doing now?
Well, came to America and started looking at what we could do in healthcare and, started learning a little bit about the systems here. So we ended up creating a company that provides a protocol compliance software, believe it or not, for privacy curtains. And then we have various unique solutions that we would consider, no ladder for recyclable curtains. Because one of the big issues in America, frankly, had been, or what we learned, was that all privacy curtains are ceiling mounted. And it kind of created this downstream issue where folks could not exchange the curtains in a timely fashion.
On one of our sister podcasts, I recently did an interview with Practice Green Health, which talks all about sustainability. So the recycling piece is kind of a recent conversation for me on one of the other podcasts. But you mentioned something else, really about, creating downstream impact and also just the state of the industry right now related to that, labor shortages, et cetera. Can you talk a little bit more about kind of what we're seeing in terms of labor and supply chain right now?
Yeah, that probably is critical and at the heart of all we do because, truly now, the whole industry is experiencing this all-time staffing crisis. You see these high daily isolation rates, which really, by the way, hamper room availability and turnover, if you will. And of course, along with that, also these issues surrounding just overall cost of goods and supply chain. When you look at, for instance, curtains, folks that are buying their curtains from China, for instance, potentially could see containers on the water currently, let's say 4 to 5 months versus pre-pandemic, maybe 2 months. So it kind of gives you a good insight, of all that's happening as a result of COVID, but also, the overall impacts of, the availability of goods and what have you.
So what have you seen in terms of the data just around, patient safety, I should say, as a result of some of these shortages? What's some of the impact that you've seen in terms of that?
Well, I think in general, I'm sure we've been keeping an eye on all the reports that are coming out and what have not. And what's of tremendous concern, of course, is that healthcare associated infections are on the rise again. And so you have, like a 35% increase during the pandemic when you look at where we were at pre-pandemic. So that's of concern. And so when you look at that, that your thoughts should probably immediately go to, okay, what contributes to these HAIs? And, of course, when you look at studies done by Dr. Rutala, for instance, it's very heavily focused on, quote, let's call it the high risk touch points surrounding the patient zone.
We've talked a lot about utilizing data to help us drive, how we make decisions. And we've talked a lot about, connecting supply chain, with clinicians in the operating room. But sometimes I'd say getting that data in a consistent way and making sure that it's accurate. This is really why we're talking today is how could we leverage technology to do that and keep it simple? But one of the things when you and I talked to prepare for the interview is you talked about ISO data. So can you define ISO and then we can take like a deeper dive into collecting that data, et cetera?
Yeah. So when we talk about ISO data, we really talk about those isolation room rates and of course in our narrow worlds of currents potentially, which is really only one of the high risk touch points, to raise the awareness surrounding all exchanges, so for instance, when you look at curtains, typically people may monitor or maintain manual logs surrounding their periodic exchanges, not recognizing that their daily ISO rate will potentially triple to quadruple the exchanges. And if you're not monitoring those ISO rates truly, you're creating a lot of risks surrounding that patient zone when you don't know for sure that you're able to validate, let's call it clean, right?
In terms of cycling the curtains in and out, then, is there a recommended time frame for how long curtains should remain in a specific area? I believe what you're saying is that every time you're taking care of an isolation patient, those curtains need to be exchanged out of the room. Is that correct?
Correct. Yeah, those are really good questions, Paul. So one of the things that we're trying to educate folks on is first off, when we look at the U.S. standards surrounding current exchanges, which we find lacking, by the way. So currently the standard in America is to quote unquote, remove upon visibly soiled or stained. So therein lies a problem already right there. because, of course, studies have found that privacy currents are contaminated with MRSA, C. diff, and VRE after just 2 weeks hanging in place. And oh, by the way, that's not a big surprise, right? Because you think about it, everybody touches that curtain. I mean, you can have the best hand washing policies in the world, but the truth is when staff walk into the room, they wash their hands, they touch the curtain, they touch the patient, they touch the curtain again and wash their hands. So that curtain is a real weak link. But coming to your next question, surrounding what should be the protocols surrounding isolation room exchanges, which is separate from the periodic and standard. There, indeed, yes, the protocol calls for bringing the curtain down and exchanging it upon each terminal clean, which is why it's so really important that folks are able to articulate that exchange and they can document it so they gather data.
Is there anything in the literature or anything that you've read relating high-touch surfaces like curtains, for instance, in the perioperative space? Because we have curtains in PACU, we have them in pre-op, and we have such a high turnover rate of patients that we are cycling patients through daily, whereas an inpatient room, that patient might be there for 3 or 4 days, but these curtains are being exposed much more to patients and to germs, I guess, for lack of a better word, just on a more constant basis. Is there a higher rate of exchange then for that if in that type of environment?
Well, again, unfortunately, it keeps coming back to that isolation room exchange. It's only under that circumstance that folks will exchange the curtain outside of their periodic protocol. And that is concerning, of course, because you have, and it kind of leads us to these, protocols in general where folks will have, we've discussed this before, but these blanket protocols that say, oh, I'm on an annual exchange. Well, as to your question, is that appropriate? I mean, should we not be looking more at who is that individual? What is the area of the facility? Let's say an X-ray changing room should probably not have the same protocol as an ICU or an ER, for instance, as to your point, right? But hopefully through data, people start learning more about the isolation room impact, and with that data, start implementing more high-risk protocols potentially.
So is there any regulatory rules currently that require the hospital to document when curtains are changed? I know you said some organizations keep a manual log, but is there any requirement to do that? Do the regulatory agencies look at that information?
Yeah, it's really interesting. Again, what our finding is that mostly these currents still fly under the radar, so to speak, but that increasingly folks like the Joint Commission might start asking questions like, what is your protocol? And oh, by the way, can you prove it? So that's starting to surface more and more. And we're really encouraged by that and hoping that it will, that the currents will fall on the list real soon. Because like in Europe, where I'm from, for instance, the NHS, they clearly have a biannual requirements and they clearly monitor the dates and whether or not these currents were exchanged on time. So, forget the isolation room exchange, but that the periodic historical exchange was done on time.
How would you document that? I mean, I realize the United States is obviously different, so maybe you can kind of give us another comparison on that.
Well, again, of course, in the U.S. currently, we've mentioned this before. Unfortunately, I would say over 90% of all facilities still document by hand. And what that entails is literally handwriting the date of the exchange on the curtain label, and then taking that information to the EVS office where they typically maintain a spreadsheet in a 3-ring binder and then document in that 3-ring binder. So needless to say, again, if you think about it, again, we've got a staffing crisis. folks are running out of time. They need to get patients in and out of these rooms really quickly. The curtain has to be taken down. Are they really documenting these isolation exchanges? Our findings are that the answer is no, understandably, by the way, as you can imagine.
So how do we get from the Flintstones to the Jetsons on that?
I know. Well, that's something that, of course, we're super passionate about. And, in terms of our own technology, we deployed NFC tags, which allows for that bidirectional articulation of what's happening in the field. So rather than saying, yep, I did something, we can now say, yes, we did something, and here's why. So that with that, you can start gathering data surrounding, these exchanges, and hopefully start coming to the conclusion, that a heightened exchange frequency makes a lot of common sense and creates a safer environment, frankly, not just for the patient, but also for staff.
I haven't been a director for several years now, but as an OR director, I always used to kind of wonder, well, gee, when are the housekeepers going to come and change out the curtains? And frequently I had to call and say, hey, I think it's probably time that you come and do this. But there was really never any time frame or that I knew of. So I think this is really important in terms of educating people in the industry about how to do this and what time frames you should be looking at. And it probably will get self-directed into organizations with some good education in this area.
Yeah, no, I totally agree. And one of the problems, though, Paul, that we do find is that unfortunately, EVS gets a really bad rap, right, surrounding these privacy curtains, whereas we would like to talk about the bad hand that they were dealt. When these facilities originally get designed in our country and they keep on mounting these tracks on the ceiling, and then you have these big mesh curtains and they're not standardized and they're very, very bulky, by the way. They can weigh up to 40 pounds. And now you've got someone from EVS who has to get on an 8-foot ladder, find the ladder, bring it to the room, figure out what height, what width, what size, what pattern curtain goes where, and then get it all up to room, get it up, and then hands in the air, grommet by grommet, exchange it. I mean, it takes, based on time and motion studies we've done, it takes 45 minutes to longer to do it. And when you've got a hospital with like 1,000 beds with a 10% daily ISO and a biannual exchange, for instance, they're exchanging 12,000 curtains a year. Can you imagine?
That's wild. No wonder it never gets done.
The only time I ever saw a curtain get changed out in our PACU pre-op at a facility I was in Texas, it was kind of all one area, just half was pre-op, half was PACU. But those curtains in there, I only ever saw them get changed out when we heard Joint Commission was coming. So I don't actually know that they had a policy or they had a standard rate of when curtains would get changed out, because it's just, like you said, it's cumbersome and it's bulky and difficult, and I don't know that I ever even thought about there being a policy on curtains before.
Yeah, and personally, I really feel for EVS departments. Again, if you would have to have heightened exchange frequencies, well, do the math. Now you need to have a lot more inventory, and where are you going to place it? You've got to have a lot more staff, going back to one patient room taking an hour plus. And you have all these risks. So, again, it's time for us to educate architects and designers on these downstream consequences and look at cost-effective, quote, what we call no ladder options.
Have there been any studies that show the relationship between curtain exchanges and hospital-acquired infections? Is there anything in the literature about that?
Yeah,
currently?
it's a great question, Paul. In fact, and that's something that people will say sometimes, well, show us where this curtain led to an infection, for instance. But then we really do like to point to Dr. Rutala's study that articulates these high risk touch points. And so the curtain is the number 6 high risk touch point. But what we always like to say, yes, and it's literally the only high risk touch point that does not get sanitized on a daily basis. So common sense would say, hey, if we know they get contaminated after 2 weeks, and yet we know that in some institutions they stay in place for longer than 2 years, I don't know. You tell me, right? But the bottom line being, it's through that data, that Justin and I spoke about on a prior call, that we believe that you start shedding light on this particular high risk touch point, and through it, you will be able to start monitoring outcomes and seeing if through heightened exchange frequencies, you can have a better outcome, frankly.
So what kinds of technologies can be leveraged to not only collect that data, but make that data more manageable? Because like you said, if all of a sudden the turnover rate's got to go up, where's the inventory? Where's the bodies to do that work? How would you even map it out? You might not even have the data to map it out. So what kind of technologies can be leveraged to get us to a point where, we have not an Excel sheet, but a really good grip on what this looks like?
Well, first off, one of the things that we created, which we felt was very, very important, is to create kind of almost like a value analysis calculator where facilities can start seeing, okay, how much inventory do I have? How many curtains per bed do we have? And what is that ISO impact? Because through that, well, first of all, it's good to know, obviously, that data, and it's absolutely imperative that we have that data, but it equally serves obviously for projecting out how much you need to have on hand, what your staffing requirements are, etc. I mean, in the end, we really found that the route to compliance really takes 3 things. Number 1, folks need to know when and where these currents are getting exchanged. All stakeholders need to be aware the quantities and types and sizes that are required. But ultimately, equally important, and especially now, obviously, is you got to have enough manpower to make sure that you can do these exchanges, right?
Mm. So one of the things you talked about in terms of taking that data and putting it to use was creating risk profiles. What do you mean by creating risk profiles? And, how would that a healthcare organization and surgical services or perioperative services specifically?
Yeah. So, I mean, obviously, if you don't have any data, you know nothing, right? And again, the impact of these ISO exchanges is so profound on the overall number of exchanges. It's huge. So when you start tracking and monitoring why you exchange occurred and when, well, then obviously potentially from that data, or at least what we are seeing in our software, you can then start saying, oh, wow, 80% of our high risk exchanges or ISO exchanges are occurring in these high risk areas. And again, over there in an X-ray changing room, we don't do any ISO exchanges, obviously. So it really helps them to focus on, kind of the 80-20 rule, right? Like if 80% of all your exchanges occur in 20% of your rooms, well then, hey, what about a more heightened exchange frequency? And then the ability to start measuring outcomes, are your ISO exchange rates coming down in those locations or not? But the bottom line is it all starts with the ability to monitor. If you can monitor, then of course you can't track it, right? You're flying in the blind, so to speak.
You were saying that, it takes about 45 minutes on average to change out a curtain. Is there any new technology out there that's reducing that time frame? I mean, there's got to be easier ways to address this, right?
Oh my gosh, absolutely. So we are literally the only country in the world that ceiling mounts our cubicle tracks. Everywhere else in the world, they use what we call suspended tracks. And when you suspend a track, well, then you get a couple of benefits. Number one, you standardize all of your curtain inventory, which is huge, as you can imagine. We recently did a study where a 1,000-bed facility had 40 different curtain types. So if you can now narrow that down to 1 to 2 curtain widths, I mean, that's huge, right? But the biggest benefit is really you and I can then walk up to that track and without using any ladders, exchange it. Right. So with that, let's say, we created a patented solution at our ends, but literally folks can exchange their curtains in 3 seconds without using any ladders or any other gimmicks. Right. But it all comes down, Paul, though, we need to start educating potentially architects and designers to really look at the implication of downstream of when you mount it on the ceiling and what other solutions are out there that can really benefit their clients down the road.
All right. So last question before we wrap. Paint a picture for the future. What can technology bring in terms of additional enhancements? You talked a little bit about current state technologies that are starting to drive it forward, especially in your area of expertise, but not even limited, just in general. What technologies do you kind of see really impacting the industry in this way, and how far can we take it?
Well, that's exciting, of course, always, and dear to our hearts. Personally, I see a future where, IoT and AI will continue to really play a huge role in the industry. And with that, what comes to mind is really folks having to do less and less, rather, through readers and through ability to participate in these new technologies, things will start recorded more automatically. So instead of people having to input, things will automatically get recorded, if you will, and the ability to start looking at reports and having AI applied, to the extent where AI will start, in essence, telling you when patients are at risk, when XYZ factors are not aligned or taken care of. I mean, that's where we believe the future is really. And then as it relates to privacy currents, I think the trend will definitely be towards embracing these no ladder solutions, by the way, Paul, because frankly, large IDNs in America are starting to disallow folks getting on ladders. Third-party service providers who are de facto the EVS or linen providers are starting to disallow it. So I think between the technology and the fact that we're getting into more streamlined work processes, I think we will see huge enhancements as it relates to the privacy current.
So you use 2 acronyms there. And before I let you go, I want to make sure we define them for everybody. We've talked about AI, and we've actually heard it as augmented intelligence or artificial intelligence. So the A in AI is up for debate, what it stands for, depending on who you're talking to. But IoT is definitely a new term for this audience as far as our podcasts go. We've never defined it before. Can you define IoT before we let you go?
Yeah, it speaks of Internet of Things and basically the ability for that to be monitored at much higher levels, potentially than, scanning technologies and what have you. So potentially we could see a future where we're monitoring how many times a curtain gets handled, and Paul, maybe that drives actually the protocol, right? Like if we're in an area of the hospital where we see that curtain getting handled 20,000 times in a week, well, guess what, right? Versus an area where maybe it got handled 5 times that week. So these are some of the things that we believe IoT can benefit on a very high level.
Excellent, Karen. That really wrapped up that painting a picture of the future really well. You did a nice job on this interview. Thanks so much for coming on the show.
Thanks for having me, Justin. It was a pleasure.
That was Karen Goelst, CEO of KleenEdge, and we're talking about leveraging technology to collect data and drive outcomes. And Melanie, I think one of the cool things that happened at the very end of that interview, as she was defining IoT as the Internet of Things, was she kind of piggybacked off that, what's the future look like, and really pulled it all together, collecting data in automated ways to ultimately drive policy and automate the enforcement and the actuation of that policy. Because I think that's the biggest thing, is so many processes in healthcare are manual, and it really makes it hard to audit. It makes it hard to keep up with. And sometimes it just places an enormous burden on leadership. And when we talk about EVS, that's a service within the hospital. It's a cost center. It doesn't tie to revenue. And when budgets get cut, that's where people go a lot of times. And now with the staffing shortage, it only makes that even more difficult of a job for a leader.
No, I get it. When I was the manager of an OR, I had plenty of things that I had to audit that were in 3-ring binders with, patient notes and various things. And to be able to use technology and use what we have to maybe do the work for us to some extent, but also to keep track of that data and then help us use that data to better our patient care. I think it's just the wave of the future that's going to make our healthcare better for our patients and for our staff.
All right. Well, that's going to do it for this week's show. As a reminder, you can help support First Case by subscribing on Apple, Amazon, or Google Podcasts. You can also find us on Stitcher, iHeartRadio, Spotify, or just search for First Case on your favorite podcast application. We also have bonus content for certain episodes, but to get that, you've got to download the smartphone app for iPhone and Android. Once you open up an episode, you can click on the gift box inside to find that bonus content. And while you're downloading the smartphone app, we'd certainly appreciate a rating and a review, because your feedback is important to the show. On behalf of Melanie, Paul, and myself, thank you for listening to this week's episode of First Case.